Welcome, everybody. This is Allie Orwig with the Indiana Rural Health Association. We appreciate your time today. Got a really very poignant, very timely presentation for you today. But a couple quick housekeeping items. We are recording today's session, so if you're not able to attend the entire time, or you think, oh, my coworker really should have seen this, we will have it up on our YouTube channel by the end of the week. Also, if you would like to ask any questions during the session, you can either use the chat or Q&A functions. You find those by hovering your mouse over the screen, and depending on which view mode you're in, they'll either pop down from the top or from the bottom. Again, you can use chat or Q&A. We'll keep an eye on those throughout. Charles, do you prefer that we hold questions to the end, or do you want me to just? Okay.
Yeah, I think so.
We'll hold all questions till the end then. Additionally, at the end of the presentation, if you would rather ask your question verbally, use the raise hand function and we can unmute your line and you can ask your question directly. So without further ado, Charles, I'll go ahead and turn it over to you.
Thanks a lot. I appreciate it. Thanks for having me here today and talking about the end of the public health emergency. Nicole, I think, had heard this presentation maybe a month or so ago, just for the holiday, the Christmas holiday, that I gave for Illinois, and asked if we could do the same presentation for Indiana. That presentation I had done with Kate Hill, and Kate's not here today, but I left much of her information in because I think it's important and relevant. So we really have two pieces to this presentation. My piece where I talk about a lot of billing issues and policy issues, things like that, and Kate Hill's slide deck that talks much more about our emergency preparedness, what to do in a survey, and how the end of the PHE affects what we need to do with our risk assessments and our internal emergency exercises that we document. So we're going to cover a lot of terrain. This is just a cool slide. I don't think it's anything. It looks like a piece of mineral of some sort, but I'm going to speed through a lot of my slides. We have a lot of slides to cover. You know me, I don't like to read material to people. We certainly will be distributing a copy of the slides in addition to just the recording. So, gosh, public health, I'm about to go to the National Rural Health Association Policy Institute right at the beginning of February here, 2.5 weeks, not even 10 days, whatever it is. And I remember right after that, the curtain fell, and such a bizarre time. It's hard to think that it was 3 years ago, but remember when we're all, many of my type of people were sitting at home, many of you folks in the clinics or in facilities, we're all wondering what the heck is going to happen? How are we going to see patients? We just kept getting this cascade of information. I think back to those times and think, oh, I'm glad we're not there anymore. So recall for rural health clinics, an enormous part of the question evolved around how we can provide telehealth services in rural health clinics during the PHE, because we had those old originating and distant site provisions. We also had a number of other flexibilities relative to eligible providers, locations, and all facility types had waivers specific to them. We had a bunch of our own. You'll see anywhere on here, most of my images are linked so that, for example, you can go back on these slides and get to those initial waivers. We're going to go through each of these waivers today and talk about where they stand. So this is a little duplicate, I think, really of what we just saw, but telehealth flexibilities, staffing requirements, physician supervision requirements, and temporary expansion for our locations were all big issues. CMS updated those blanket waivers fairly recently, 3 months ago, on 10/13 of 2022. And again, you can follow the link once you get to these slides, and we're going to go through the language that they updated in 10/20 10/13 of 2022. Excuse me. The first of these, this is the language directly from the waiver. Telehealth flexibility. Remember now our wonderful G2025 code. We were able to waive our originating site and distance site provisions, but this G2025 is not a rural health clinic encounter payment. It's an aggregate. Anytime we see these G2025 codes, that's an aggregate code. It's not an encounter, but it's a payment that we receive. And all of these flexibilities we got were set to end 151 days after the conclusion of the PHE. Well, the status of those flexibilities is nobody wants to go back to originating site, distance site rules. We're almost 3 years into this. There's no way to put that genie back in the bottle. In the long term, we do not know what is specifically going to happen to G2025. So we still have a 151-day waiver after the end of the PHE that will continue to utilize G2025. If you recall, a few months ago, before CMS started to issue these 150-day durations after the PHE, we weren't sure what was going to happen. And theoretically, the PHE could have just ended and then G2025 would have gone away. Now that's not the case. We're going to use G2025 and continue providing telehealth services. I think we've backed far off the number of telehealth services we are providing, but there's still some 151 days after the PHE. We're going to see shortly, some of these, particularly with behavioral health, have changed. We already have new laws and new provisions that start to chip away at the flexibilities we need extended. And many of these flexibilities have already been made permanent. We're going to talk about some of the various aspects of the things that are included under G2025. Some of our waivers will cease. In particular, telephone only. I think telephone only as part of our telehealth visit will go away. I'm skipping around a little bit, but our behavioral health services have already been formalized. Many of us know about that. We're going to cover that in a second. And as with Indiana and Illinois and many states surrounding you have already codified permanent telehealth rules that allow us to bill patients when they're outside the clinic, that old originating site thing. Indiana has already changed those. So you've got permanent flexibility now at the state level. We're going to cover that too. So major changes already for telehealth. Anything at the CMS level is typically announced for rural health clinics is announced out here at this Rural Health Center website. It's actually Rural Health Clinics Center for CMS, not to be confused with FQHCs. And we always get our payment updates, notifications. You know, hospice is now included. It's not a PHE extension, but any of our big CMS Rural Health Clinic updates, they're typically populated out here on this Rural Health Clinic Center website of theirs, which you can see what that address is right there. Of course, you can use your Googler and just go type in CMS Rural Health Center and you'll come up with it. Since we're talking about G2025 and what the status of public health emergency waivers are, well, we know we're still in the PHE. The PHE was just updated again. I should have thrown in a slide. PHE just updated, I think, on 1/12. So it's extended again. We're still firmly in the G2025 era. And this next year for 2023, remember G2025, the payment for that is a composite or aggregate of all of the services that are listed in the Medicare physician fee schedule that are eligible for telehealth. There are 279 of them, I believe. And the national average of those services comes out to $98.27. You see, we have our other G code populated there, care management services, both flavors, as well as our virtual coordination services that we'll also touch on. behavioral health services via telehealth have changed. The very first thing, with the first change that was made permanent, was that CMS determined, it was a rule change, that visits now include the definition. See over here, this is part of our definition of our rural health clinic definition. That's where the definition of a visit can be found, which includes this language right here. That basically a mental health visit via telecommunications face-to-face is now an encounter. It's no longer a G2025. It's now a full-blown encounter. Remember, telehealth was really initially most often implemented in the behavioral health realm, where the patient was at the clinic, which was the originating site, and we'd have the provider at a distant site. And much of that was used to see behavioral health providers remote to the clinic. Now, that remote provider, patient, wherever the patient is, the rural health clinic patient, and the provider is on the rural health clinic clock, i.e. cost report, this is now an encounter. It's no longer a G2025 service. So furnished using interactive real-time communications technology. And let's see, I've got this panel hides some of what I do here. So this includes audio only visits. So for behavioral health encounters, audio only still applies. We can talk about all the reasons for that. That's a different conversation. We know our patients don't have a lot of cell phone usage or, cell phone access, etc. So we do include audio only visits as behavioral health encounters. Medicare built in a 6-month visit requirement that there would be this is part of what's hanging up G2025. Are we going to implement an in-person visit requirement for G2025s? When we came out with behavioral health rules, which is what we're talking about now, the behavioral health rule, creating a behavioral health encounter, requires an in-person visit to have taken place within 6 months prior and every 12 months after, while behavioral health services are being provided. They immediately poked exceptions into it that said, hey, if this is detrimental to the patient's care, you can waive the in-person requirement. And oh, by the way, for at least 151 days after the end of the PHE, the in-person requirement for behavioral health services via telehealth is waived. As with all things, again, genie out of the bottle, I don't see the genie going back in the bottle. I think we'll see a comprehensive policy for some kind of in-person requirement for telehealth visits, but that's not what we have right now. Right now, we have the in-person requirement for any ongoing and initial in-person visits to establish behavioral health service via telehealth is now waived. We have 2 different modifiers. We're going to look at a modifier CG, of course. No longer will we use the G2025. We're going to use the actual code. Modifier 95 for audio and video, and FQ for audio only. I've got a couple of examples. 95 audio and video like we're doing today. FQ audio only. You'll see we have the behavioral health service that is one of those from the rural health clinic qualifying visit list. I should really update my dates on that, but you'll forgive me, I'm sure. Medicare is really down on audio only visits, even though we in the rural health community really shout as loudly as we can, hey, we do not have cell phone and access to smartphones and computers like our urban and suburban counterparts do. A lot of our areas have 50% penetration of cell phone and computer at home use, 50%. So that's pretty staggering. So while Medicare has said we don't like audio only, we've said, please don't take audio only away. That's still under that. That's why we're hung up on what to do long-term with telehealth visits. I just want to say right here, don't forget about virtual communication services. Remember, this was originally intended for those 5-minute. It's not an encounter, doesn't lead to an encounter, doesn't stem from an encounter, can be telephone only, could be a text, can be an email, and at least 5 minutes of communication. And oh, I don't have my current rate on there, but G0071 is what you use for those, hey, quick patient status updates. This would include a telephone only kind of check-in type of thing. $23.88. Again, it's an aggregate code that includes virtual care management services, as well as some of our telephone only codes. So those are in place. And there's what I just said. Remember, telephone call, some kind of, maybe a quick video clip that is uploaded to you. Remember, Facebook is not HIPAA compliant, but somebody texting you a picture, maybe not FaceTime, you know what I mean. Quick audio visual check-in, less than 5 minutes is not part of an encounter. If it becomes an encounter, then you build an encounter. Remember, the virtual check-in initially said the virtual check-in has to be initiated by the patient and it can only be on an established patient, both of which were waived for COVID-19. This established patient reaches out to you, we can't be cold calling our patients, but that particular aspect, even though my formatting is a little off, is waived for COVID-19. Remember, 5-ish minutes of discussion, not part of an encounter. And there is coinsurance. Remember, there's coinsurance on G2025 as well. CS modifier waives coinsurance. And of course, one would anticipate CS modifier going away after the end of the public health emergency. So beneficiary consent, we do still need to obtain the beneficiary consents to be seen via telehealth communications. It should be in the note somewhere. It needs to be just part of our consent forms anyway, but consent and coinsurance certainly apply. Now, state Medicaid agencies, you all have a pretty good one. We could all have our quibbles, but the language is a little strange in how the policy for telehealth was written. Indiana RHC Medicaid policy was updated last I see 7/21 of 2022. This is all their language right here. Special consideration, billing considerations apply for RHCs, FQHCs, but ultimately the reimbursement for encounter T1015 or D quadruple 9, I assume that's an FQHC encounter, based on your PPS rate. So you're going to get paid the rate for Indiana Medicaid telehealth encounters, but man, we still have this, should have highlighted it. They still make a distant site thing. So we still have distant site, originating site language in the Indiana Medicaid policy, which is a little strange. But really what they're saying is, we'll see here in a moment, they still want that old Q3014 for originating site to be placed on the claim. And we have these special considerations because we're going to bill T1015 with an appropriate procedure code. See if I came back here. I didn't include the full language in there. I encourage you to go look at the actual policy, because what Medicaid says is both of these are reported. We're going to pay both of these as encounters, distant site and originating site, but they want it reported. And of course, we're going to report a CPT code that represents a visit as detailed along with the T1015. So we have to report a CPT code that's a visit, evaluation management, whatever it may be. We're going to put a modifier on it. We're going to put a place of service, depending on if it's originating site or where the patient is. So please, I encourage you to go out and look at these. So remember, if the patient is, the RHC is the originating site, that's the patient is at the clinic, but the provider is at home, for example, or in the suburbs somewhere where they may live. Let's go back here. If the RHC is the distant site, it's not exactly explicit, but that would be where the patient is not at the clinic and they're seeing a provider that's on RHC time. So this is being determined distant site and originating site by where the patient is located. CMS, or excuse me, Indiana Medicaid, they want us to include the telehealth originating site facility fee with our encounter. This is when the patient, I don't think this is going to happen very often. So I think this is much ado about nothing, shall we say, because I think most of our telehealth visits are going to be the patient is not at the RHC and the provider is on the clock, maybe not necessarily at the RHC, but on the RHC clock. It's confusing, I know. The short version is, the takeaway is, that we don't have a differential in payment. Originating site, distant site, Indiana Medicaid, it's all paid at the encounter rate now. We have some coding issues on how to get there that perhaps explore. Oh, there you go. D99 is the dental code. So we have some differences in billing. If you have more particular questions, we can sort through some of those. Let's talk about the other waivers. Remember our staffing flexibility waiver that we got? So 50% of the time the RHC has nurse practitioner, et cetera, et cetera. Just for the record, the 50% rule was in place if you became a rural health clinic, if you're newly accredited RHC during the public health emergency, but then immediately after you became approved, the 50% waiver went into effect. So you do not necessarily have to have a nurse practitioner PA 50% of the time for an existing RHC. What I did here was I included language from the 2022 update on each of these flexibilities that CMS, now this was back in 10/13 of 2022, back in 3 months ago, but boy, we've had some things start to move quickly on this front. So we're going to see a couple of those in just a second where they've already changed some of them, and CMS on our staffing waivers, they're exploring options to make many of these flexibilities permanent. So they're exploring options on the 50%. That'd be a big statutory change for rural health clinics. This is a huge one. We're looking at the flexibility for the requirement for physician supervision. What this has evolved into is that CMS is currently set to return to those rules, but we're really looking hard at options to remove the physician supervision requirement and explicitly, this is not written in here, get rid of the chart evaluation component, the chart review component of a program evaluation. Remove physician supervision, the chart evaluation component. A lot of these since the fall are starting to at NARHC, we have a working piece of legislation. It's not official yet, but we're including these provisions in some working policy asks that we're doing of the feds to include these flexibilities. We're calling that the Rural Health Clinic Burden Reduction Act, burden reduction. It includes making these staffing flexibilities permanent, as well as a few other things that if those fell would be a huge deal. Remember, we could set up a temporary expansion location. RHCs were pretty firmly bound to our brick and mortar address, but as RHCs, we could go set up shop in Walmart parking lot and see patients. A lot did, and those would have been encounters. Those will end at the end of the PHE period. But remember what we also found out. Seeing patients in your parking lot is an encounter. You're at your street address. If you have a temporary expansion at a different street address, it's time to either make that a permanent rural health clinic or get ready to consolidate back to mothership. That flexibility for expansion locations will go away. Remember that we also, because of coronavirus outbreak, even the OIG got in the act and allowed us to waive co-insurance at our discretion. That was to get people to come in, just be seen, unstick the wheels. We could waive co-insurance just arbitrarily across the board if we wanted to. Certainly that will end. I don't even hear much of that anymore. But of course, we don't have cost sharing on COVID-related services or COVID-related illnesses, of course, services. I don't know what other word I'm searching for there. Our ability to waive coinsurance in general is going to go away. So just remember that's still been lingering out there, and we don't anticipate that to move. Part of the huge gift that it takes our ability to do behavioral health via telehealth and supercharge it was the Consolidated Appropriations Act of 2023 that we all know as the omnibus spending bills that Congress now uses because we don't ever pass individual pieces of legislation anymore. They have to attach everything to this omnibus package because it's the only thing, the only legislation that's generally going to pass. And we all know why. We don't have to go down that road. Omnibus packages are where we generally get our big policy changes. One of the very last things I got to do as during my now completed term as president of NARHC, I'm no longer the president of that organization. Mandy Shalas has taken over that, but I got to do some great stuff during my whole term, but especially at the end, because I got to announce or help announce this major expansion of behavioral health services, rural health clinic services, that finally our behavioral health providers, mental health counselors, our LPCs, CPCs, marriage and family therapists, a couple others. Indiana already has all of these providers defined as encounters. It's one thing, the argument we kept making to CMS, hey, the states are way out in front of us on this. Indiana, Kentucky, a few other states already recognize LPCs, CPCs, these so-called behavioral health counselors. Now CMS has recognized mental health counselors, marriage and family therapists as approved providers, just like LCSWs and clinical psychologists. They will be able to bill an encounter. Now, we don't have any rules in place. I think that CMS, I haven't read this, but I've been told a year that we'll put the rules in place in 2024. But regardless, this is a major expansion. So not only do we get these new providers, but they'll be able to see patients via telehealth. So we don't have to take up space in your clinic. If they're on your clock, excuse me, they can see patients for you. Huge expansion. I think it's a giant deal. Now, part of our Burden Reduction Act for the NARHC, this increases exponentially the urgency of us getting straight or have come to some kind of clarification and modification on a requirement to have 51% of our services primary care and not behavioral health. We're getting a little off the PHE topic, but it's rolled up into all of this, is that if we have this major expansion of providers and such a great need for behavioral health services, we've got to get the 51% rule moderated somehow. 51% is a made up number. It's not in any statute or legislation. 51% comes out of a CMS interpretation, which makes it arguable. So big expansion of services. Behavioral health counselors are going to become rural health providers. Telehealth encounters are going to be payable. They already are at the Indiana Medicaid level. So that genie is not going back in the bottle. Now, let's switch gears. Let's switch from billing and policy initiatives to rural health clinic compliance. These are Kate Hill's and compliance team slides. I hope I do Kate some justice, but here we go. 491.12, we all know, emergency preparedness took on much more significance as we hit the COVID pandemic. Number of waivers that were included in, remember when I said the 51% primary care? That comes out of the Appendix Z State Operations Manual, which is the update for emergency preparedness provisions. So this is the guidance that's given to surveyors by CMS. And the new Appendix Z update is we've got to verify facilities have policies and procedures placed in its emergency plans to talk about alternate care sites in the 1135. That's what these waivers are. And so much of this is the fancy technocrat way of saying a lot of this is now cooked into Appendix Z that CMS goes by to evaluate emergency preparedness plans. So big update here is that EID, your hazard risk assessments need to encompass emerging infectious diseases. So just like we did tornado, just like we did plant explosion, just like we do school bus accident, now we need to have emerging infectious disease in our hazard risk assessment. We also need a plan, of course, of how we're going to deal with that. And we'll take everything we know or have learned from the COVID emergency and build into those plans. And those plans need to be quote unquote aligned with our state and local emergency resources. And a plan is not a plan if it's just in someone's head. It needs to be in writing. We all can talk about all of the lessons learned since we have entered the school shooting era. I'm sure we can all tell stories at this point. North American has a client that was triaging his son's high school classmates at a school shooting in Kentucky. So obviously we have to have active shooters and shooting, catastrophes in our hazard risk assessments. What are your local weather conditions like? We're in Indiana. Certainly we could talk about flooding, but we're not going to talk about hurricane. So our hazard risk assessments need to encompass the things that are likely to happen in our area. Of course, we're all tornadoes. We do earthquake over here in Missouri. Yeah, maybe you should there too, but we all need to update our hazard risk assessments to reflect local conditions. You also have to have your exercises aligned with the things that are in your hazard risk assessment. So if you're doing a school shooting exercise, that needs to be in your hazard risk assessment. You can't just test the same thing year after year and give the same processes. The whole intent of these hazard risk assessments are to identify gaps. So gotta have exercises you're using in your risk assessments. You are not required to use volunteers in your rural health clinics during a public health emergency or during an emergency. You're not required to use volunteers. We do need to state in your emergency policies whether or not you are using volunteers. At the rural health clinic level, you're probably not going to use volunteers. You might, but it is a survey question now. This was, I remember, coming up prior to the COVID emergency, and everyone's like, what? Volunteers? What are you talking about? So we just had to vote no volunteers. So we do have to address volunteers in emergency preparedness plans. So there have been some changes to how to participate and what types of exercises and how often you need to participate in them, and especially as the public health emergency ends. So remember, we have to participate, and we had some of these changed. These changed right, but along with program evaluation requirements. Remember, we could start alternating tabletop exercise, community-based exercise every other year. So remember, we can still do that. 1 year of full-scale exercise. We have to have then one other as a tabletop, and we're alternating the years on these. I'm a little less familiar with some of this material, so if I say something that's a mistake, we'll clarify it with Kate. So every other year, we have to have a full-scale or at least a clinic-based exercise at least every other year. Remember, that used to be annually. Now it is every other year. And the most important part is to analyze the responses to the exercises or activations of a plan. And remember, as we already stated, the exercises must be on your hazard risk assessment. Oh man, so this goes back to, and I don't want to try to read through this. I'll let you all read through this when you get the slides. So this has to do with if your current COVID emergency counts for your exercise or not. And it all depends if you have formally resumed normal operating status. If you've resumed normal operating status, you've got to, let's see, is expected to complete required full-scale exercise in 2022. And then, so it all depends. Say if you've never deactivated your emergency plan, it changes when you're going to have to do the full-scale exercise. If you've gone back to normal operations, then and are using your 2022 activation for your exercise, then your next full-scale exercise will be in 2024. So there's been an update on the timing with which we need to do these annual exercises. That's the important takeaway. So let's see. So this is really relative to the same thing, whether or not you've been on an activated emergency plan, or if you've had to activate another emergency plan on top of it. So we've got some exemptions, and exemptions do not accumulate or carry over to other exercises. So, you know, the example given here is if you've had a winter storm or a wildfire in the midst of your public health emergency. So you've got two separate emergency activations there. The most important part is the after action report. It's a review of the exercise. Where were we strong? Where did we fail? And whether or not the exercise was successful, and what would make it more successful in the future. And that can be used after an exercise. The after action report should be used after an exercise or an actual event that occurs. For example, if there is unfortunately some kind of a shooting incident. There's a sample of the after action report. This is the one for the public health emergency. And again, we outline what needs to be in your after action report. Electronic health records. You can no longer have your electronic health record. So now EMR is now the standard, but the big lesson is we've got to have those servers and the backups off site. You've got to have those backups off site. So we can't have just a server and your backup right there. So we've had a lot of additions and updates to the status of EHRs in our emergency plans and how we get access to those, to our electronic health records during emergency events. It's a lot of ease in there. Incomplete emergency preparedness plan is the biggest reason people are getting condition level deficiencies right now upon survey. Surveyors are out, state surveyors are out. Certainly compliance team, don't forget Quad ASF is out there. They're also doing surveys, resurveys, not having updated your emergency plan, your hazard risk assessments for current emergencies, not updating hazard risk assessment for emergency infectious diseases, and not having the appropriate exercise and the plan being incomplete have all been big sources of deficiencies. Have you addressed volunteers in your emergency plan? Number one reason for condition level deficiencies. That other big reason we're seeing everybody get hammered with program evaluation deficiencies. So get your program evaluations updated because the surveyors are out looking for them. Exercises, drills, tabletops. Do you have your training documented? Can you present? Do you have the documentation available so that if somebody shows up, you can show them your training documentation? Did you write them up? If they didn't do, it's just like a medical record. If they didn't do them, they haven't happened. So here's some suggestions on after action reports, a couple resources for that. And it's a fantastic resource for all things emergency preparedness is this Asper Tracy resource. More information than you'll ever know what to do with, but definitely when you're looking for emergency exercises or forms, a hazard risk assessment form, these are a great place to go find some of that. So remember, our core elements of emergency preparedness is the risk assessment and emergency planning, hazards likely in a geographic area. My wife is over in Eastern Illinois, just across from Terre Haute. There's a big marathon plant there. So of course, everybody has to have marathon plant explosion in their emergency plan. We always think about care-related emergencies, mass events, anything like that. Power failures. Here's a big one. Power failures, communications. But what about if you can't get into your facility? We've had at least one client whose facility burned down overnight. We've had certainly, a water main break and the clinic is flooded. So what are you going to do if all of a sudden you can't get into your facility and use it? Or what happens if one of those same events you've lost a major portion of your drug supply, for example? So include all of these things in our hazard risk assessment, and our plan has to be updated at least every 2 years. And your number of risks match the number of emergency plans you have to deal with those risks. What are your communication plans? What are your policies and procedures? Have you been trained and tested? And documentation with logs and signatures for all training, including after action reports. The training and testing is not valid without after action reports. Remember, our policies and procedures now have to be updated biennially that include evacuation, how to shelter in place, how to access and preserve medical records, and whether or not, again, you're using volunteers. Hazard risk assessments can be community-based and clinic-based. Another good example of the clinic-based is, hey, we've had somebody coming in armed looking as a domestic violence situation. Community-based and clinic-based. Try to think about the things you haven't thought of. It's a fantastic this hazard vulnerability HVA analysis tool has been the standard since emergency preparedness became a requirement. I've been using it forever in our own stuff. So it's a really excellent vulnerability tool. Remember, it comes with a lot of templated material. Make it your own. Don't just take the templated material. Well, good. So we made it all the way through. I hope I didn't go too fast or too slow, whatever the case may be. But
no, not at all. That was a lot of information, but I think in a reasonable amount of time.
Good.
I didn't actually have any questions come in during the session, but if anybody wants to chat in or use the Q&A function to send in a question now, or if anybody wants to use the raise hand function, we can unmute your line and allow you to ask a question as well. We'll give it just a few minutes here. But a ton of very, very important information in this presentation. Charles will be sharing the slides with us so we can share it out to all of our registrants today. Again, the recording will be posted to our YouTube channel by the end of the week. You're able to access that anytime. Just really appreciate everyone's time. Nicole, Charles, especially the two of you for bringing this information and presenting this information. We so appreciate it.
It's my pleasure. Thank you for having me.
I'm not seeing any hands or questions, so I think we'll go ahead and adjourn for the day.
Thanks
Thank you,
everybody.
everyone.
See you soon.
Charles.
Bye-bye.